Good morning, one and all. At the outset, first of all, I'd like to thank the organizers for giving me the opportunity. I'm going to speak a paper presented by Dr. Michael Zalewski at the ASTRO 2022 in San Antonio, and we know he's a very well-recognized radiation oncologist, especially focusing the genitourinary tumors. So he spoke about the superior post-treatment biopsy outcomes with high-dose SBRT compared to high-dose conventionally fractionated IMRT for clinically localized prostate cancer. Dr. Zalewski has been instrumental for justifying the role of SBRT in prostatic tumors, and he already had a lot of papers which emphasize the prognostic significance of a negative post-treatment biopsy result after high-dose IMRT, highlighting his team's prior work demonstrating that patients with a negative post-IMRT biopsy had significantly improved PSA failure, distant metastasis, and cancer-specific mortality rates. The aims and objectives of this study was that it is to retrospectively compare the post-treatment biopsy outcomes of prostate cancer patients treated with high-dose conventionally fractionated IMRT versus high-dose SBRT. The study had about 416 patients with lower intermediate risk prostate cancer who underwent a post-treatment biopsy following the high-dose EBRT. So this biopsy basically was a scheduled biopsy. It was nothing related with the PSA report or any other features seen on the radiological grounds. The 186 patients were being treated with conventional fractionation IMRT with a median dose of 81 gray, and 230 patients received SBRT to a median dose of 40 gray in 5 fractions. The biopsies were performed 2 to 3 years after radiation therapy with a median 12 to 15 course. Looking at the baseline patient characteristic, about 80% of the patients in this cohort were NCC and intermediate risk group patients. The use of short-term ADT for 6 months was more common in the patients with the SBRT arm, that is 84% versus 56%, and expected radiation dose was higher in the IMRT group, that is 81 gray versus the 40 gray. So the results were the proportion of the patients with a positive post-treatment biopsy was significantly lower in the SBRT arm, 11% versus 38% in the IMRT arm, with a significant p-value of less than 0.001. And it bears note that these were not those patients, as I mentioned before, they had a PSA relapse or something seen on the radiological grounds, but this study already had a prior scheduled biopsy. Incidence of the post-treatment biopsy, however, was being found to be significantly higher in patients who did not receive ADT, that is 28%, as compared to those who received ADT is 13%. So what results were seen was restricting the analysis to the patients with unfavorable intermediate risk group and looking to the ADT use among the IMRT versus the SBRT cohorts. The authors determined that the use of ADT in these patients was associated with a decreased incidence of positive prostate biopsy, irrespective of the radiation regimen being used, that is IMRT or SBRT. And the multivariable logistic regression analysis evaluating predictors of a positive post-treatment biopsy demonstrated increased odds in the following subcohorts of IMRT conventional fractionation with the odds ratio of 2.7, no use of concurrent ADT as odds ratio of 2.2, and unfavorable intermediate versus low or favorable intermediate risk, that is with the odds ratio of 1.43. However, there is no sufficient evidence to suggest that the effect of hormone therapy on the biopsy outcomes differed either between the two radiation types or between the different risk groups. So to conclude from this study, among the patients, mostly the intermediate risk group, who underwent post-treatment biopsies following high-dose radiotherapy, the most significant variable associated with an improved biopsy outcome was the patients treated with SBRT as compared to IMRT. There was a trend for significant reduction in positive biopsy outcomes for patients treated with short-course ADT with a p-value of 0.05, and improved local eradication of prostatic disease appears to be more frequently achieved with high-dose SBRT, likely in combination with short-term ADT. I did not know the pattern of today's conference, but that's why I have put 2-3 papers, but I'm sure Ritika would take this forward in her panel. When we talk about the use of ADT with the SBRT, you would find many papers advocating it and many papers against it. Like this is one of the paper in the 2020 where they showed that the effect of ADT on the long-term outcomes of intermediate risk prostate cancer, especially the secondary analysis of the RTOG 9408, it had proved to be beneficial. And it did support the NCCN's recommendations also for the use of ADT. Another paper published in the European Journal of Cancer 2021 had the same interpretation where the ADT was found to be beneficial, whether it was a radiation dose of 70 or a dose escalation of 76. Another in the 2019 where in fact they've said that men who are 70 years or younger with favorable intermediate risk prostate cancer treated with radiation alone to 70 gray are at increased risk of biochemical failure. So even in this favorable group, they advocated the use of ADT. And then there are papers who would be not very much in favor of using ADT. Like this is a meta-analysis published in 2022, which says that ADT plus radiation did not provide OS or biochemical relapse-free survival advantage in the intermediate risk group of patients. Similar such studies. There were certain papers, very recent papers, who also has observed that there are disparities in the terms of socioeconomic grounds when we are advocating ADT with SBRT or IMRT in the intermediate group of patients. But finally, one last paper, which is about the SBRT and the androgen deprivation therapy for localized prostate cancer, recently published in 2022, which says that SBRT dose of about 42 gray in 7 fractions with the short-term ADT represents a very safe and effective method for the unfavorable and high-risk prostate cancer. So probably I think with this paper, where we don't have much randomized or more properly defined patients, we still have more time to count on this conclusion, and probably a more better designed randomized trial will be giving us better information. And I'm sure Ritika will take this forward in her panel discussion. Thank you for being a patient audience.